Hi everyone, thanks for listening to all my presentations. I have published presentations on hepatitis A, B, C, and D. Today I'll be rounding up with hepatitis E. Hepatitis E virus is very common, but surprisingly, it is the least diagnosed. Worldwide, there are about 20 million infections every year. Hepatitis E virus is a small single-stranded RNA virus. It belongs to the family of Herpesviridae. There are genotypes 1 and 2 of hepatitis E virus that are confined to humans. Also, we have genotypes 3 and 4 that are found in animals and humans. So we can just summarize that genotypes 1, 2, 3, and 4 will be found in humans, while only 3 and 4 are found in animals. Genotype 1 is found in Asia, India, and North America. Genotype 2 is found in Mexico, West Africa, Asia, India, and North Africa. Genotype 3 is found in Western countries, Asia, and North America. Genotype 4 is found in Asia and Europe. Outbreak in Lake Chad occurred in 2017, that is in Africa. Rates are higher in developing countries, but it is widely spread in Europe. For example, there was a widely spread report in Germany, France, Netherlands, and Switzerland. The risk is higher in non-Hispanic whites and those keeping pets, those eating liver or other visceral more frequently. Chronic hepatitis C virus infection and a very high hepatitis E virus seroprevalence have been seen. Transmission. The incubation period for hepatitis C virus is between 15 to 60 days. Contaminated food or water will be the major source of transmission. In other words, it is a waterborne infection. It could also be transmitted via blood transfusion. Vertical transmission from mother to child in pregnancy or during birth is possible. It is not so clear about breast milk transmission, and person-to-person transmission is less common, but that is not completely ruled out. Transmission is highest during fecal shedding, so fecal-oral transmission. Genotypes 1 and 2 could be transmitted fecal-orally in poorly clean endemic zones. Genotypes 3 and 4 could be spread via zoonotic transmission from meat consumption or shellfish on cruise. Still on transmission, pigs are the mostly implicated animals when it comes to zoonotic transmission of hepatitis E virus. Shellfish will be second to pigs, particularly on the cruise. Rodents are not ruled out because they serve as reservoir. Undercooked beef, like there, visceral, sausage will be the route, mostly in Japan and Europe. Cow milk was suggested to be responsible for genotype 4 transmission in China. Transmission to rhesus macaque has also been recorded. Some authorities recommend boiling liver for a long time, and that is expected to decrease transmission. Clinical features, mostly asymptomatic, and when there are symptoms at all, it will be very mild. And the symptoms are even non-specific, so we could be dealing with nausea and vomiting, anorexia, malaise, fever, diarrhea, or pruritus. Still parts of the clinical features could include arthralgia, jaundice, urticarial rashes, hepatomegaly. I've made a separate presentation on differential diagnosis or causes of enlarged liver, meaning the differential diagnosis of hepatomegaly. You can check my channel for that, please. Hepatic decompensation can occur in individuals with pre-existing liver disease. That is not to say that pre-existing liver disease is the only cause of hepatic decompensation. No. More chronicity with people who are at the same time having human immunodeficiency virus and organ transplantation. Let me explain. There is likelihood of hepatitis C virus becoming chronic if the affected individual is at the same time co-infected with HIV or he or she had organ transplantation. Extra-hepatic clinical features, meaning we are likely going to be faced with some signs and symptoms that are not related to the liver. But it is all because we have hepatitis E virus, and now other organs are suffering as well. So we could be dealing with acute pancreatitis here. You can check my channel for presentation on acute pancreatitis. So I'll not waste your time going into that. Lipase, amylase, level of insulin will give us clear. Thrombocytopenia, on account of which the individual might start bleeding, and that will give a picture when we have complete blood count with platelets. Hemolysis, we will know with the level of anemia, LDH and haptoglobin. And here we'll be dealing with unconjugated bilirubin in hemolysis. Aplastic anemia is likely. Thyroiditis, on account of which we will embark on thyroid function test when we reach how to make the diagnosis. Membranous glomerulonephritis, and that is why we will do renal function test in anyone where we suspect hepatitis E virus. Meningoencephalitis or transverse myelitis all could occur as part of extra-hepatic clinical features. We're not done yet. Still on extra-hepatic clinical features, there is likelihood of aseptic meningitis, Pseudo Tumors cerebri, Guillain-Barré syndrome, cranial nerve palsy, peripheral neuropathy, or neuralgic amyotrophy. In other words, many organs like pancreas, like the kidney, like the thyroid, and of course the brain can suffer just because there's a problem occurring right there in the liver, now spreading wide, affecting all organs in the body. How do we make diagnosis of hepatitis C virus? We need to take thorough history, travel history, the clinical signs and symptoms, and of course, thorough physical examination. And after that, we'll head into the lab. For what? You'll know in a bit. And if we are not yet convinced with the diagnosis, or we've not really honed down on the diagnosis, we can embark on radiological investigation as well. Now we're at the lab. After the young man or the young lady are taking the sample and we're expecting the results. Okay, we might be dealing with increased level of ALT, and when antibodies to hepatitis C virus is assayed and we find IgM, that is pointing to recent infection. So antibodies to hepatitis C virus with rising IgG is indicating that this is a remote infection and it could be recent. But we need to know this, that IgG antibody to hepatitis C virus can be in the system for as long as 14 years, meaning the individual contracted this virus long time ago, more than a decade, either got treated or because self-limiting and the whole thing disappeared, and then the person didn't even know that it was hepatitis E virus because it just nausea, vomiting, weakness, and then mild diarrhea, and life continue. Now, more than 10 years after, IgG is indicating that this guy or this woman had hepatitis E virus in the past. That doesn't mean the person is sick today. Okay, we might be dealing with increased AST as well, and complete blood count would give the picture of either anemia or thrombocytopenia when platelets is assayed. We will also assay for the level of hepatitis E virus RNA, which will be pointing to chronicity. We want to come down on the definitive diagnosis, then we'll embark on Western blot or enzyme immune assay. We can have stool for hepatitis E virus RNA, and that could be assayed at 1 week before the illness. And someone will ask me, how do you mean? 1 week before the illness? Does it mean you will know ahead that next week this individual will have the illness? No. When there's outbreak in an environment, you can just use the stool for screening generally. So you embark on thyroid function test. Remember, we said there will be extra-hepatic features, or that it will affect the thyroid gland. So thyroid function test. It will affect the kidney, so we have renal function test. Liver will suffer the most, liver function test. We'll have ultrasound, and we have CT. CT because it's going to affect the pancreas, it's going to affect the brain, so we want to see what is happening. What are the possible complications? There is likelihood of acute liver failure, cholestatic hepatitis, and of course chronic hepatitis E virus. Hepatitis E virus and pregnancy. Here we may be dealing with more acute liver failure and of course more mortality. Mortality here could be as high as 15 to 25%. If pre-pregnancy exposure to hepatitis C virus has occurred as a younger woman, that will reduce the degree of severity later in life if infected with hepatitis E virus in pregnancy. Pregnancy with poverty, poor nutrition, and poor immunity will lead to poorer prognosis. What are the possible differential diagnoses of hepatitis E virus? Like I said from the beginning, that I've published all presentations on hepatitis A, B, C, and D, including the pathophysiology, the clinical features, the symptoms, prevention, and treatment of all this. I have. Check my channel for that, please. So it could be herpes, it could be Epstein-Barr virus, it could be cytomegalovirus, could be toxins, or alcoholic hepatitis. Could be Wilson disease, could be autoimmune hepatitis, hemochromatosis, alpha-1 antitrypsin deficiency, non-alcoholic steatohepatitis, Budd-Chiari syndrome, and HELLP syndrome. Still on differential diagnosis, remember we've gone through the list of possible extra-hepatic features. So it could be thyroid disease, could be adrenal failure, could be anorexia nervosa, particularly in young women that is having severe nausea and anorexia. Could be celiac disease, particularly in those with diarrhea and muscular diseases because of possible GBS as part of clinical features. And with that, I've come to the end of this presentation. The next presentation will be on hepatitis C virus prevention and treatment. Remember to subscribe to my channel. Remember to share. I appreciate it.